Are we able to share our screen?
Yes, I'm just going to share my screen really quickly for the CME information, and then I will give it over to you all.
All right.
I think if you'll get it if you expand the whole window.
It says host disabled participant screen sharing.
One moment.
Early last night. Yeah. Storm.
Oh, because of the storm?
Yeah.
I don't know. I just kept waking up. Maybe it was a storm.
Yeah, this was like rolling thunder nonstop for a couple hours. Yeah.
I just remember waking up and
the dogs are going nuts.
Twice.
Yeah. Okay, so we are.
Y'all talking about that storm last night?
Yeah, it was.
I know it woke me up. The thunder like shook my house.
Yeah, both of us.
I was like, what the hell?
Yeah.
Apocalypse? For real?
Mm-hmm.
Oh, God. At least there were no trees down. That thunder was loud.
Not here.
Yeah.
Anybody live on the North Shore? No. I heard they got it. They got 16 inches.
Wow. Jeez.
All right, good morning, everyone. Welcome. We are just getting started. Sorry for the slightly late start. I am going to post a screen for CME credit. If you would like to get CME credit, just change your name to your LSU email address, please. I'm going to show these slides. And then we are going to turn it over to Crystal Oliveira, the Chief Development Officer from the LSU Health Foundation.
Hello, everyone. Thank you for joining us for our ongoing coronavirus web series featuring our healthcare experts from LSU Health New Orleans. We're so glad you are joining us this morning. Today, we have a very interesting discussion that you may have seen in the news recently, and we are exploring the possible link between vitamin D and COVID-19. With us today is Dr. Frank Lau, Associate Professor of Plastic and Reconstructive Surgery and CEO and co-founder of ExoCell, along with Dr. Patrick Greiffenstein, Assistant Professor of Clinical Surgery at LSU Health Sciences Center. Doctors, welcome. We're grateful to have you here. I'm excited for your presentation.
Thank you.
Thanks.
We got to share the whole screen.
Are y'all able to share your screen? Did I get?
We are now, yeah.
Okay.
Let me just get this up and running. Sorry, technical difficulties.
No problem.
It's not the full.
There we go.
Can you guys see that?
Yes.
Okay. All right. Well, thanks for having us. I'm Frank Lau, and this is
Patrick Greiffenstein.
Patrick is actually on the ground frontline worker. He healthcare worker. He does took care of a lot of COVID ICU patients when we were really at our peak. So it's really an honor to have him join us on this.
It's an honor to be here. Okay. I don't need to go over too many details. I think everybody's aware of this bug has been on the news pretty much nonstop for the last 4 months, if not a little more. For the record, the virus name has changed, been officially changed by the International Committee on Taxonomy to be called the SARS-CoV-2 virus, or SARS-CoV-2 virus. Although a lot of people still use it, and we all still use the term COVID-19. But if you ever see that terminology, that's why it's there. To date, it's responsible for about 4.3 million cases worldwide. 300,000 people have died in the world since this has begun. And it has, in an unprecedented fashion, completely shut down the global economy. It is a very different disease on a number of levels. Very early on, by the way, the medical ICU who's typically the group taking care of severe respiratory illness caused by viruses and other sort of infectious pathogens, MICU became overwhelmed. The overflow cases came to us. Now, the surgical ICU is typically not taking care of these people with primary respiratory problems. So this was a coordinated effort that was taken on by all the specialties and leadership. And it was a process of learning as we went. And we learned from each other, text messaging, even things like social media were instrumental in helping us understand what we were dealing with and how to approach it. Typically, like I said, surgical intensivists are very adept and commonly treat patients with respiratory failure, but it's not typically their primary problem. It's usually respiratory failure as a result of some other problem, either surgical disease or trauma. The whole thing really posed a lot of unique logistical challenges and procedural challenges, but there was something that we didn't expect, which is that the disease itself was a little different. And required us to approach it in a somewhat different fashion. For the record, I would assist in the care of patients in the ICU. The primary people taking care of the ICU patients were Dr. Lance Stuckey, who was on service at the time, and primarily the fellows and senior residents. So I was a supplementary figure, not the lead person taking care of these things. Just to give credit where credit is due. Let me tell you a little bit about acute respiratory distress syndrome, which is a sort of an umbrella term for this severe inability for the lungs to work. And it can be from a variety of causes. It can be from direct lung injury, such as pneumonia, or in terms of trauma from direct lung bruising, or it could be from a remote insult, such as shock, sepsis, major tissue damage, systemic infection. So, and what happens is that there's an inflammation, and when this inflammation is overwhelming and goes throughout the entire body, it leads to inflammation in other organs. So the lungs can be injured and inflamed, the kidneys will be inflamed, the gut, the liver, the brain, really virtually all the organs in the body are going to be potentially involved and inflamed. Now, ARDS used to be called wet lung, and there's a reason. That's because whenever there's inflammation, there's usually a lot of wetness, right? So we call it edema, and it's basically just the fluid in the tissue sort of leaks out of the blood vessels and into the tissue itself, and makes the cells swell, and that causes a lot of problems. And when you think about the lung is very similar to a sponge in the way that it's characterized, and the way that it looks, and its anatomy and its structure. So just the difference between just to visualize it, the difference between a wet sponge and a dry sponge. Interestingly, COVID lungs, patients with suffering from ARDS from COVID infection, the lungs were not particularly wet. They had unique characteristics. Early on, the radiologists were seeing such a specific pattern on their CT scans that they were actually talking about making the diagnosis solely on the basis of radiography. As we got more and more cases, that became a little more nebulous, but I think it stands the test that these lungs had a characteristic feature in so many cases that it really sort of struck a chord in terms of a pattern that we were seeing. The inflammation was patchy for the most part. Instead of being, the entire lung, it was sort of patches of affected tissue. The thing that we were seeing on the ground is that patients did not have high amounts of secretions. When patients are intubated and they're suffering from respiratory failure, very often they're bringing up a lot of fluid into their lungs, into their airways, and that requires the nurses to suction them out on the ventilator frequently. Fortunately, that was not the case. With a few exceptions, most of the patients did not require very frequent suctioning. It was sort of, remarkably dry from that standpoint as well. The other thing that was salient in these patients was the idea of a silent hypoxemia. Now, hypoxemia is just lack of oxygen in the bloodstream. So the lungs are taking in the air, but the oxygen isn't making it into the bloodstream. The reason it was silent is because when patients usually have severe respiratory failure, it's typically involving wet lungs. And so wet lungs are stiff and hard to breathe with. And so what was causing patients to feel like they couldn't breathe was the fact that they couldn't move air in and out because the lungs were wet and stiff. If the lungs aren't wet and stiff, they were able to breathe comfortably. So they weren't even aware that their oxygen level was low. They weren't very often aware that they weren't getting enough oxygen in the bloodstream because they were able to move air in and out. And so they didn't have that same characteristic air hunger that some patients get. And remarkably, some patients would go from being awake and talking to you to suddenly, coding and dying within a matter of just a couple of hours. It happens so quickly. ARDS is something we've been dealing with for a long time. But the COVID ARDS is unique, right? Broadly speaking, who gets it? Elderly people, right? We've heard about the age characteristics of these patients, but elderly people do worse in all kinds of disease. Obese, hypertensive, diabetics, also patients who are characterized by doing worse with COVID, but then they've always done worse with everything else that they contract. So in general, it's not surprising, but why are they dying of respiratory failure? And why are the lungs so dry? Why is the lung compliance so good while oxygenation is so bad? Briefly, let me tell you about multisystem organ failure, because it doesn't always just involve the lungs. When more than one organ system fails, you have worse outcome and significantly worse mortality. Why are these patients' kidneys shutting down so frequently? Why are they clotting off the dialysis catheters? Very, very early on, we realized that once we put a catheter in a patient, within an hour or so, the catheters would fill with clot, and we'd have to either replace them or deal with them in a very expeditious manner in a pattern that we hadn't seen before. It was so frequent. Virtually everybody who got a catheter clotted it off that we began the practice of putting people on blood thinners immediately upon giving them a catheter. So why was that happening? And then afterwards, one of the things we found was that they would recover from their disease or not, and we would try to wake them up from the sedation, and they would never wake up. Unfortunately, they were also too sick to bring to the CAT scan or to the MRI to look in their brain and figure out what was going on. They were too sick to be able to do that. So unfortunately, on a number of occasions, we just had to let people go because they just never woke up, and they had characteristic features of people who'd suffered major brain injury that we suspected could have been some kind of a stroke. So why was all of this happening? I think that as clinicians, we always try to find a unifying theory, and that's really the right way to approach these problems is finding one cause to all of the different manifestations. So understanding what's happening at the tissue level, why the lungs are being affected primarily, why the kidneys are shutting down, why they're clotting, try to bring all of that together into a unifying theory is really the challenge. And when Dr. Lau approached me with his theory, which we'll go into in a minute, it really struck a chord because it made sense on so many levels. And so I'll hand it off to him, and he can tell you why that is.
Thanks, Patrick. So just to kind of recap, in terms of looking for a unifying theory, there were a number of mysteries that we were trying to explain with a single idea, right? And so the first is, we saw very divergent outcomes between patients who caught COVID. About half of the patients had no symptoms at all or had very mild symptoms, whereas only about 15%, which is still a very large number, but 15% became severely ill and required hospitalization. We know that COVID, as Patrick just said, COVID initially targets the airways and the lungs, but severe illness involves everything. Silent hypoxemia without the stiff lungs, kidney failure, stroke, blood clots everywhere, and heart disease. And all of these, as Patrick mentioned, can be linked to too much clotting. The third mystery, which is a little more recent, was that homeless populations actually appear to be protected. And this is unusual because they generally have poorer health, generally have worse nutrition, they get less vitamin C, vitamin B, and zinc, and so forth. But many get a lot more sun exposure just because they're outside more. And kind of maybe in a similar fashion, smokers generally have much worse outcomes when it comes to a respiratory illness. But smoking in COVID doesn't seem to be a risk factor for getting severe disease. So if you think about what smokers have to do, they go outside a few times a day to have their cigarette breaks, and they might get more sun that way as well. And the fourth mystery is that, there are some populations that we know are more at risk. Patients with darker skin, such as African Americans, patients with hypertension, diabetes, and obesity, men are more at risk, and also people who live in northern climates. All of these things can be linked to vitamin D as well. So what is vitamin D? Well, it's sometimes referred to as like the sunlight vitamin, because 80 to 90% of the vitamin D in our body can be produced by exposure to sunlight, especially between the hours of 10 a.m. and 2 p.m. Vitamin D can be found in some foods, such as fatty fish like salmon, and many dairy products are also supplemented because vitamin D deficiency is a real problem and is very common throughout the world. Vitamin D, we know, prevents too much clotting. We also know that it's used by the immune system to fight viral infections. And when vitamin D levels are low, we call that vitamin D insufficiency, or VDI. So, there's a lot of theories floating around out there. There's a lot of misinformation floating around out there as well. And I think if everyone recalls, early on, there was a thought that hydroxychloroquine and some other medications might be helpful in COVID. And so one of the questions, is for the average person is, how do we decide if low vitamin D is truly linked to COVID, right? And so there's kind of a framework that I like to use, which is a 4-step process. The first is you look for circumstantial evidence, right? So these are just sort of, if you think about the movies, they're looking for a killer or something, and or trying to solve a mystery, and they've got a board up and they've got red string and pulling everything together. That's what I would consider circumstantial evidence. If there's enough circumstantial evidence to pursue a theory, then we go on to the next step, which is to perform observational studies. So we look at patients who have COVID and sort of see, okay, what does vitamin D levels look like in these patients? And then we say, okay, well, if vitamin D is low in a lot of COVID patients, can vitamin D explain the mechanisms of disease for what we're seeing? And then really the final step, which is the most critical step, is do a clinical trial and see if vitamin D can actually improve COVID outcomes. So in terms of the circumstantial evidence, we've covered some of this already, but do you want to go over this?
So some of the associations that we could see, like I said before, is that certain populations are affected by this disease, but again, some of these populations are affected by all diseases in an unprecedented fashion. But if you can line it all up with incidence of vitamin insufficiency, then maybe we have something. We look at African Americans, of course, currently they correspond with 70% or more of patients who have died in Louisiana, and that's a significant amount larger than the overall population of African Americans in our state. And it also correlates with an 82% prevalence of vitamin D insufficiency. Same thing with the elderly, 2 to 4 times the hospitalization rate with a significant prevalence of vitamin D insufficiency. Hypertension, very prevalent among patients, which was kind of unusual. Why were hypertensive patients suffering from lung injury in a manner that, for example, smokers weren't? If you look at the independent risk factors, again, very significant incidence of hypertension among patients who did worse with COVID infection. And the same thing with obesity and male to female ratio as far as vitamin D insufficiency. So all of these things kind of tie up. The red strings that Frank was talking about really begin to kind of point at one thing. And I think it's our duty to see if those things are pan out to be true.
And so also recently, there's been a number of epidemiological papers that are coming out. This one was recently published or pre-published out of Northwestern, where they looked at vitamin D levels in elderly patients in a number of countries, and they compared them to the mortality rate or the death rate in COVID patients. And so basically you see the two charts, they form a V. So in countries like the US, where vitamin D concentrations are higher in elderly patients, you have lower death rates. Whereas in the UK, where you have the lowest vitamin D concentrations in elderly patients, they have the highest death rates, right? So this is, again, intriguing, but still circumstantial because it doesn't get down to the individual patient level. But more and more, we're seeing papers like this come out. And we have a team working on a similar paper as well, looking not just only at the elderly patients, but also at all patients of all ages. So step two then, so sort of the next higher level of evidence is what we call observational studies. And so what Patrick and I were able to do, along with some of our other colleagues, was to ask the question, how common is vitamin D insufficiency amongst COVID ICU patients? So we looked at two ICUs, one at University Medical Center New Orleans and one at Ochsner, and we checked vitamin D levels on all those patients, and it turns out 93.5% of them, so almost all of them, had low vitamin D levels. This was 29 out of 31 patients. We looked at some non-ICU patients in the hospital as well, and it was only 60%. And we know that in the US, in the general population, it's only about 30 to 40% of patients who have vitamin D insufficiency. So this type of observational data suggests that there may be a dose response curve, meaning, the lower your vitamin D levels, the worse your disease is going to be. Taking it up to the next step then, can vitamin D levels actually explain what we're seeing in COVID? And so this is a working hypothesis. All of this is pulled from information that we know about vitamin D, that we know about immune systems and clotting, but has not yet been proven in COVID. And part of our team's job, which involves a lot of people now, we're up to about, I think, 15 people working on this, is to prove or disprove whether or not this is actually happening. So this is pretty exciting for us. So we start with the virus, COVID, and in a patient with normal vitamin D levels, what we think is happening is that the upper and the lower airways become infected. So that means, the nasal passages, the throat, and down into the lungs. When COVID replicates, COVID is an RNA-based virus. So when COVID makes copies of itself, it produces what we call double-stranded RNA. So two strands of RNA intertwined just like our DNA is. And it turns out that respiratory cells that line our lungs and our airways, when they detect that double-stranded RNA, they actually activate vitamin D. So they turn it from a 25 hydroxylated form to a 125 hydroxylated form. And our bodies use this activated vitamin D to generate antiviral molecules such as LL37 and beta-defensin. And so these molecules, these proteins, are part of our body's natural immune response to help control the virus replication. It slows down the virus. The activated vitamin D is also used to activate macrophages, which are immune cells that attack and destroy our own cells that are infected, right? So if you can imagine, if that doesn't happen, the virus can continue to reproduce a little more out of control. So again, this is a second form of innate viral control in a healthy patient with normal vitamin D levels. And so the purpose of all this viral control is to give our immune systems time to develop what we call a humoral response or an antibody response. And once those antibodies produce, then the body can much more effectively fight off the viral infection. Now let's contrast that to what happens in a patient who has low levels of vitamin D. So the virus gets into the body, it starts reproducing, it makes a double-stranded RNA, but if vitamin D is too low or is absent, as we saw in some of our ICU patients, they had undetectable levels of vitamin D, then you can't make the molecules or the vitamin or the macrophage activation to generate that viral control. And so we think that this allows the virus to more effectively enter the bloodstream because there are more copies and the defenses just aren't there. When it enters the bloodstream, what happens? Well, it infects the cells that line the bloodstream because they have the ACE2 receptor as well. And when those cells become damaged to line the bloodstream, they naturally form clots. This is part of how we stop bleeding when we get cut or injured, right? And it also turns out that not having vitamin D creates a pro-thrombotic state or a pro-clotting state, because some of the some of the brake pedals that prevent too much clotting, such as antithrombin and thrombomodulin, require vitamin D for production. So here we are, we've got clot forming in the blood vessels now because the virus has escaped the lungs. And so, in the lungs, what happens? Well, you can end up with clots throughout the lungs, which can lead to what we call infarcts, or basically miniature strokes of different parts of the lungs. And that can explain the silent hypoxemia that Patrick was mentioning. When the clots get to the kidneys, that can cause kidney failure, requiring patients to be on dialysis. They can get to the brain, causing strokes. They can, in the news in the last couple of weeks, there's been a lot of coverage about, COVID patients' toes turning purple and so forth. And that can also be seen when too much clot is formed. And same thing with just rashes throughout the skin. This has been a focus of a couple of news articles as well. So when all these systems get damaged at the same time, then we enter the state of multisystem organ failure, which is when we start to require hospitalization or the ICU. And that's when mortality rates bump up to about 50%. Now, kind of more dangerously, all this diffuse clot formation actually consumes the factors that are leading to even more clotting. So it becomes a positive feedback cycle. And similarly, when you have tissue necrosis, right, when tissue starts dying off, the body's response is to break down that tissue, and that too can lead to a cytokine storm, and also a condition potentially called secondary HLH. We'll skip through some of that. But secondary HLH can identify many of the features seen in the sickest COVID patients, such as high ferritin levels and so forth. And so when cytokine storm happens, that feeds back into more clot formation because of the increased inflammation. And it also feeds back into macrophage and immune system dysfunction, right? So this, again, there are multiple positive feedback loops once we hit this stage of very bad organ diffuse clotting and organ damage. And so here's how the whole picture looks. So, in a patient with low vitamin D, we do have a potentially explanatory mechanism for why they get so much sicker than the average patient with a vitamin D level. Okay, and then so the last step then in our framework is to go out and prove this definitively, right? So a prospective randomized controlled clinical trial is the gold standard. So we're working on developing that now here at LSU. We call this the COVID-19 trial. The LEAD stands for low risk, early, aspirin, and vitamin D. This is prospective, it's randomized, it's controlled. We're now partnering with multiple institutions around the country who want to be sites for this. So this will be the highest gold standard trial for these interventions. And the purpose is to try to prevent hospitalizations in COVID patients. So where does aspirin and vitamin D affect the cycle where we're trying to intervene? Right here, we're trying to prevent the downstream effects of the absent or low vitamin D, and also to slow clotting through a baby aspirin. And I'd like to thank everyone for their time and for listening.
Hey everybody, thank you. So how many people just went on Amazon and ordered a large jar of vitamin D capsules? So that was very interesting. And we actually have quite a few questions for you. So we'll get started with, so this was back at earlier in your presentation, but someone asked, is it suffering from hypertension or controlled history of hypertension? So you might have to think back to what you were talking about.
I don't know that anyone has really picked that out yet. All the studies, most of the studies picking up hypertension, they don't go into that level of detail. It's a good question though.
Yeah, right now it appears to be history of hypertension. The problem with hypertension is that it's not a snapshot diagnosis. So if you just show up to the doctor with high blood pressure, they're not going to put you on blood pressure medication. it's a repeated pattern and observation that your blood pressure tends to be too high. The problem when you go to the hospital is that your blood pressure tends to be too high. Everybody's is. So is that because they're uncontrolled? Is that because they're under stress? Is that a response to the stress of the infection? Is it because they just saw a doctor? So there are too many things that put that in the weeds. So right now, all we can say is patients who have a history of hypertension are at increased risk of developing severe cases of COVID.
Okay. This is sort of do you recommend everyone in the general public to start vitamin D at this time? And if so, what dosage?
Well, you know, vitamin D has a lot of benefits in addition to the immune system. It's good for bone growth, for bone health. And so, you know, supplements are actually not the best way to get the vitamin D. Just getting 10 to 15 minutes a day between the hours of 10 a.m. and 2 p.m. of sun will make you feel really good, and it should boost your vitamin D levels as well. So getting outside a little bit and just getting a bit of sun certainly can't hurt anybody.
Right.
10-minute, 15-minute walk during the day, maybe after lunch, would be more than enough for most of us. Now, if you're particularly dark-skinned, you will probably need more. I don't know, and Dr. Lau may be able to answer that more in detail. I don't know how much more, but if you have darker skin, you may need to expose yourself a little bit more.
Yeah, the estimates are anywhere from 3 to 5 times more. Right?
Okay. So what is the reasoning for the lower vitamin D levels in the African American community?
Their darkest skin just has more melanin, which the purpose of the melanin is to absorb UV rays. So by absorbing the UV rays, they basically have sunscreen on all the time, and that blocks the sun.
Okay. And what about, do you recommend a low dose of aspirin? I assume that's what ASA is, aspirin.
Yeah, so that we wouldn't do yet because there is, you know, long-term use of aspirin was studied fairly intensively in patients who had heart attacks, and it turns out there's about a 1% risk of bleeding if taken for a year, right? And so while the numbers are small, if suddenly 300 million people took a baby aspirin every day and 1% of them developed a bleed, you know, that would still be a large number of people, 3 million people or so, right? So, I think until we have this clinical trial up and running and we get some real results from it, it's not something that I'm prepared to recommend yet.
Okay. And that's actually what somebody asked. They said that this is excellent information. I've seen articles about this topic this past month, but they haven't explained the science as well as this. How can we follow along on your research in this study?
Well, we hope to continue to put out papers, and we've been getting a fair bit of press coverage on this. So I think one of the things we'll end up doing is setting up a website to help people track the progress of the study.
Okay. And we can also push that out on the LSU Health Foundation social media channels and on our website too, as that stuff comes out. We have some more questions. As a pediatric orthopedic surgeon, I've been seeing an incredible number of patients with vitamin D insufficiency and true deficiency despite plenty of sun exposure. It's a paradox. Do y'all have thoughts on
that? Is that African American patients?
Hold on one moment. I will allow Dr. Acute to.
I mean, we do know that vitamin D insufficiency is endemic in the U.S. and around the world. In the U.S., the average is 30 to 40% in the general population. In African American patients, is anywhere from 80 to 90%. Nutritional intake is going to be part of it. Sweden as a country did a very good job systematically reducing or improving their vitamin D levels. And so part of that is they eat a lot more fatty fish. And they've also supplemented all their dairy products with vitamin D. And so, in patients who do have persistently low levels, despite having adequate sun exposure, probably supplementation is going to be required, but maybe also an endocrinology workup.
Okay. I did unmute Dr. Acousti if you want to ask your question or speak any more to that topic.
Sure. I've been over the last couple of years, we've been seeing an incredible number of patients with vitamin D insufficiency. One, we're testing more often, and it may be just prevalent in general, but there is some theory that potentially the thing that's changed over the last couple of years, that kids are now all looking at iPads and our tablets and phone screens throughout the day, and that the blue light emitted striking the retina has definitely been shown in some studies to definitely affect hormone levels. And the theory is that the body is being tricked into thinking it's gotten 18 hours of sunlight because you're being exposed to a certain wavelength of blue light at 8 o'clock at night, and the body is down regulating conversion. Just a theory, it's not been proven, but that's the only thing. I have colleagues around the world, and they call it the Mediterranean paradox. They have all these patients with vitamin D deficiency despite plenty of sun exposure, and everybody thinks it's because kids are wearing sunscreen, but we don't need much sun to get exposed on our arms to normally convert vitamin D. And we have kids, athletes that are outside all the time, and we live in the South here. There's no shortage of sunlight. We're still seeing incredible number of vitamin D deficient kids. So, and it's causing a number of orthopedic conditions that we just didn't see before, such as Scheuermann's and osteochondrosis. So it's endemic, and maybe that's why we're seeing a change. Maybe it's the tablets. There are blue filters, and there are some people suggest that kids should be having blue screen filters or using certain special glasses. I really can't speak to the efficacy of those things, but something to consider as a little potential preventative medicine.
Okay. Thank you. Do you all, there's actually another question along those lines. Do you all have any recommendations in light of the new inflammatory syndrome that we're now seeing in children? And I know that there's not a lot of cases. Do you all have, and I know I hate to ask you to make a recommendation, but do you have any thoughts about vitamin D for children right now?
Well, since I think the 1950s, they've been fortifying milk with vitamin D. And
even orange juice, I see.
And now orange juice and other things are fortified with other. I mean, it's a great sort of systemic response to a deficiency problem. It's why salt has iodine in it. It's why milk has vitamin D in it. And vitamin C in orange juice. So what we're doing as a society, or the retailers of the world, or the food producers of the world, are trying to address a problem by adding it to the diet. So I would say that within reason, if you can increase what your kids are getting safely, you can add multivitamin to kids' vitamins. You can increase their exposure to sunlight. Maybe even get one of those Blu-ray blue light screens for your iPad. I mean, I don't think any of those things are either terribly expensive or extreme or dangerous. So if you're concerned about it, I would throw everything at it until we figure out exactly where the deficiency lies, where the bottleneck is. I don't think it's unreasonable to just avail yourself of the ways in which you can prevent this, and add them all. I plan on instituting some things. I'm going to go out and look for blue light screens for my kids' iPad. Not that they only get about 30 minutes to an hour a day, but I'm going to start looking at.
Can I chime in for a sec? I know it sounds crazy, but it's funny. The one kid I had tested, very few kids test, like our range of normal in our lab is 30 to 100 nanograms per deciliter for the vitamin 25-hydroxy. And even it's rare to get a kid in the normal range over 40 to 50. And the one child that I tested who had a vitamin D level of 65 was the only kid that the parents made them wear blue light filter glasses, all the kids in the family. And he's a surgeon in town, and I thought he was nuts, but that's the one kid who had a vitamin D level of 60. And just to add, vitamin D is put in milk and orange juice, but if you really look at the levels, it's quite variable, maybe 60 to 100 units in a serving of milk, which is, I'm giving kids 4 to 5,000 units a day to get their levels up into a normal range. We're also checking parathyroid hormone levels, and even with a vitamin D level of 28 and 30, they still have PTHs that are elevated at 85. So there's My goal, at least in these kids with any orthopedic musculoskeletal symptoms, is to get their vitamin D levels up to 50 or 60. And I suggest getting tested, having them tested with a vitamin D screen and a parathyroid hormone. It's such a simple, cheap, inexpensive test, and it could maybe it provide us some protection. That's all.
This kind of work, and thank you for bringing all that up, because this is the kind of work that could help answer that question: is whether it's the cofactor or just one of the cofactors that we could then turn around and implement more globally. Maybe it's the kind of thing that kids should get checked with every checkup, and it should be the kind of thing that's more globally screened. And just for reference, Dr. Kusti, the levels that we're seeing in our sick people in the ICU here are like negligible. One patient had a result of vitamin D level less than 7. It was essentially indetectable with the methods we have. Only people, and Dr. Lau didn't get into this, the only people who had normal, or the few people who had normal vitamin D levels and were really, really sick were over the age of 75. All of the young people, especially the young people who were really, really sick and either were dying or had potentially died already, when we went back and looked, had very, very, very critically low levels of vitamin D. Definitely not a cause and effect yet, but I would certainly call that a smoking gun.
Okay, we do have a few more questions. We have in the HIV clinic, we have been testing vitamin D levels in our patients for years, and really the only person I am seeing with normal vitamin D levels, the only people I'm seeing are white guys who do yard work, I'm guessing, but I would say 80% of my patients have vitamin D deficiency.
Yeah. Well, there is a question which we don't have a view or an answer on, which is the vitamin D being consumed in the process of fighting the disease? So it is possible as well that if you have any kind of disease that targets the immune system or generates a more intense immune response, for example, that the vitamin D might get consumed as well. When we look at sort of larger scale studies, which we're starting to do now, we're seeing that the vitamin D insufficiency is present in about 60% of COVID patients so far.
Okay.
Higher than the average general population.
All right, going back to, and I actually think this viewer wrote, how do you explain that, as you mentioned, the homeless population is more exposed to sun but have worse clinical outcomes? Is that what y'all said, or did you say they actually had better?
So they actually had better. So the initial study came out of a homeless shelter in Boston, which is one of the hotspots actually for COVID. And they tested, I think, about 350 patients, 350 persons for COVID. 160 came back positive, and none of them had any symptoms whatsoever. No fever, no cough, nothing else. And so that the CDC picked up on this mainly as a story of how much asymptomatic spread could happen. And they went ahead and tested 3 other homeless shelters around the country and found very similar results. So, while it is true and important to understand and recognize that this does show that COVID can spread asymptomatically, from our perspective, it also suggests that homeless persons are protected somehow from having symptomatic COVID disease. And so kind of in picking out, okay, well, what are some of the factors that might be protected from homeless persons? I think exposure to sunlight really stands out as a possibility.
Because everything else they do is a risk factor. Everything, if you think about it. And if you think about the close proximity with multiple strangers without any available means of preventing transmission, compare that with, for example, the experience of nursing homes and advanced age care centers in the city alone. We have 45 deaths to date from COVID among nursing homes in the city. Mm-hmm. And they implemented pretty early isolation practices. So we have 2 populations whose really main salient features is age, who are in close proximity with each other. One has an extraordinarily high mortality risk. One has a remarkably low mortality risk.
Yeah. Okay, well, just two more questions. Which did you test, D3 or it says hydroxy form? I don't know if that's a typo.
We tested for 25 hydroxy, I think should be D3, yeah. I'd have to go, the tests are run by the hospitals, and the different hospitals assign the test to different labs. So the methods are a little bit different, test to test, site to site.
Okay. All right, that is all the questions we'll be taking today. Do you all have anything else you want to add?
No, thank you all so much for listening and tuning in.
We're so grateful that you're here, and I wanted to let everyone know that we at the foundation are going to be launching our coronavirus response campaign. And this research is going to be a big part of our response to how LSU Health is answering the call of coronavirus. And so I'm going to be posting a link in the chat that you guys can go and you can make donations that will support this research and other ongoing research that will make an impact on coronavirus. And thank you both so much. I mean, this was so informative, and we're so lucky to have such amazing researchers and faculty right here at LSU that we can support. So thank you for your time.
Yeah, thank you.
Thanks, everyone.
Thanks a lot.
Stay
All
safe.
right. Take care.
Get some sunlight.
We'll do it.